Okay, good afternoon, everyone. I know the circumstances are um, not appropriate, no, for discussion, but I will record this in advance just in case stable na mo, no. So you have opportunity, you now have an opportunity to readily watch the videos in advance. Now, before we start, no, let's have a short prayer. This is for the patient, for the people who are affected by the recent typhoon, and also this is for those who are about to take the Philippine Nursing Licensure exam scheduled tomorrow. Okay, so let's have a short prayer song, no?
By the hand and help me face the rising sun. Come from me through all the pain that life made me. There's no other hope that I can lead me, Lord. Lead me, Lord. Lead me all my life. Walk by me. Walk by me across the lonely roads that I may face. Take my arms and let your hand show me. Show the way to live inside. Show the way to live inside your arms. All my days, all my life.
Okay, so that's it, no? Hopefully you are well. Hopefully you are doing great, no? I know the circumstances are quite severe, especially in Cebu City. Ayaw sa, okay. Para na nasa sunod simana, no? So hopefully you are well, no? I'm gonna get this take this opportunity to tell you that if you are having difficulty, please inform the faculty, because no, if there is another round of relief goods, then basin pwede mo maunahan, di ba? We can prioritize you. So let's get to work, di ba? Let's get to back to business, no? So we've already discussed pituitary agents, thyroid and parathyroid agents, and adrenocortical agents. Today we're gonna discuss anti-diabetic agents. Now forgive me because this is gonna be quite long, no? So especially the pathophysiology of the disease itself, I have condensed it down to its most simple form. However, don't worry because it will be discussed once again in your medical surgical nursing. Okay? So our anti-diabetic agents are used for diabetes mellitus. Okay, they are indicated for diabetes mellitus. Now, what is diabetes mellitus? No, diabetes mellitus is an endocrine disease. It is an endocrine disease characterized by sustained, that is the keyword, the keyword is sustained high blood sugar or blood glucose, no, or blood glucose. Okay, now we will discuss later on what are the types of diabetes mellitus, but just note that there are two types of drugs involved when it comes to anti-diabetic agents. There are insulin replacements and oral hypoglycemic agents, no? These adhere to what I have already discussed before, wherein endocrine drugs either replace the hormone itself, or they will stimulate the presence or the production of hormones. Okay? So let's start with our insulin replacements. Now, I know you've heard about insulin before, but what does it mean? Unsa may function? What is its function in the body? Now, let's start with where it is produced. This is our pancreas, class. This yellow organ here. This is our pancreas. Okay? Now, the pancreas is special, class, in that it has both an exocrine and an endocrine function. Okay? Its exocrine function is mainly for digestion. Okay? Mainly for digestion. Why? Because it will secrete specific pancreatic enzymes. Like for example, class, your lipase, your amylase, and then your protease. Okay? These are enzymes that will help digest, no, specific types of food composition. Okay? Whereas our endocrine function of the pancreas is your for blood glucose control. Blood glucose control. Okay? It works in tandem with your liver, class. But basically, your pancreas will secrete insulin. This is from the beta cells, glucagon. This is from the alpha cells, and somatostatin. Somatostatin. This is from the delta cells. Okay? Now, I have a memory trick for this, no? So that you will not forget. My memory trick is this, no? I have a friend, class. His last name is Reyes. Like this, no? Reyes. Okay? Ako na siya. He's my very close friend, no? Very, very close friend sa nursing. Up until now, no? And I always mention this when I'm discussing endocrine or when I'm discussing diabetes mellitus. I always bring up his name because it never let me forget, no? Kini si Mr. Reyes. Okay? Si Mr. Reyes, bigaon na siya, class. Bigaon. Okay? For those of you don't understand bigaon, it's it means promiscuous. Now, why am I, tungod siya kabigaon class, no? Tungod siya kabigaon class, no? Daghan kay siya, he has a lot of explicit images in his SD card. Okay? He has a lot of explicit images in his SD card. Now, why am I bringing that up, no? Why am I bringing that up, our class? BIGASD. Okay, tanawa ha. Biga is D. No? The beta cells will secrete insulin. The alpha cells will secrete glucagon. Ayan. The delta cells, no? The delta cells will secrete what? Somatostatin. Ayan. Oh. So I am using, no, the discredit of my friend. Ako siya gidaot class so that you will learn. Okay? I hope you appreciate what I have done for you. No? I will tell him about this again para maka-realize na po siya. Now, I keep talking about these three hormones. No, they are very important. So what are the functions of these three hormones? Let's start with insulin, class. Insulin's function, to simplify it, it will move glucose. It will move glucose towards or into the cell. Okay? In turn, it will decrease blood glucose. Okay? It will decrease blood glucose. Our glucagon, okay, it will promote production and movement of glucose into the bloodstream. Okay? So it will increase blood glucose. Keep that in mind, ha? They are counters to each other. Okay? The third one, class, somatostatin. Okay? It will regulate. Okay? Regulate the release of insulin and glucagon. So it is the controller for these two hormones. Now that is basically our pancreas. Now let's move on to the physiology of what happens. Okay? Now normally, this first slide is normal ha. Normal ha. I will put it here. Normally. Okay? Normally, when the person, class, eats, kung mukaon ang tao, class, no? When the person eats, if you consume food, okay, then there will be an initial increase of glucose. Ayan. So this is the bloodstream, ha? There will be an initial stream of blood glucose, increase of glucose. Now, we call that, class, no? We call that postprandial hyperglycemia. When we say postprandial, class, it means after meals there is an increase in blood glucose, no? Postprandial means after meals. Okay? Now, because there is an increase in glucose, listen to me, there is an increase in glucose, the pancreas, specifically the beta cells, will secrete insulin. The one here in green. Okay? It will secrete insulin. Now remember, class, potassium sometimes is often, no, in your bloodstream. There is some excess potassium. Okay? Excess potassium. Now, what insulin does, aside from moving glucose, okay, is it will also move potassium. So, what does it do? Now, class, listen to me ha. Follow me, okay? Now, our insulin, listen to me, will go to your insulin receptors. Wala, di na ako maliyot, class. Ako na lang drawingon. Our insulin will go to our insulin receptors. and they will bind with our insulin receptors. Now, class, when you are thinking about insulin, class, no? When you are thinking about insulin, think of insulin as like a key. Mura siya giyawi. Okay? Insulin will bind to your insulin receptors so that your GLUT4 or glucose transporter will open up. Okay? So they will bind to the insulin receptors to open up your glucose transporters. And because of that, class, no? Because of that, the glucose, the one here in blue, is now able to enter, no? Is now able to enter our cell. Okay? Is now able to enter our cell. Now, let's say for example, kasi ito yung reason ha. See for example, the glucose and the potassium is now able to enter the cell. Now, look. No, nasa suit sa cell. Okay? Now, that is a good thing, class, because the cells, listen to me, the cells require glucose in order to function. And it is also good so that the glucose is not stuck in your bloodstream. Okay, the glucose is not stuck in your bloodstream. So, insulin is very important because it will move the glucose away from the bloodstream and into the cell where it will be used to create energy. Diba? Remember, there is a need for glucose when it comes to the production of ATP. Diba? So, yan na siya, that is normal functioning. Normal functioning. Now, here is type 1 diabetes mellitus, also known as your juvenile diabetes, also known as your insulin dependent. Now, the reason why it is called juvenile, class, is because it occurs, listen ha, it occurs at childhood. Oftentimes, this is genetic diabetes, no? Or inborn diabetes mellitus. Now, what happens in type 1? Now, the main problem in type 1, class, okay, at ibutang nila, the problem with type 1 diabetes mellitus is that the pancreas cannot produce insulin. Okay? The pancreas cannot produce insulin. So, there is no insulin. Okay? The pancreas cannot produce insulin because type 1 diabetes mellitus is an autoimmune process. It is an autoimmune disease that attacks the pancreas and insulin. Okay? So, that's why it's called insulin dependent, class. Because since there is no insulin, you need to give the patient insulin. Diba? Kaya wala may insulin, the pancreas cannot produce insulin. So what happens is this. Now here is what happens. Okay? Here's what happens. After you eat a meal, okay, after you eat a meal, no? Humani mo kaon, class, there will be a lot of glucose. Okay? Naapod na siya, there is also a few potassium there, di ba? And potassium is normally inside the cell. We want to put it back inside the cell, no? The problem there is since there is no insulin, walay insulin, class, since there is no insulin, okay? There is no way to open up our GLUT4 receptors. There is no way to open up our GLUT4 receptors. So what happens, class, is the glucose will stay in the bloodstream. Okay? The glucose will stay in the bloodstream. Now, what if 6 hours later, mukhaon na po ka, class, you're gonna eat again. So, you're gonna put more glucose inside the bloodstream. Okay? And that is now what we call, class, the major sign and symptom of your diabetes mellitus, hyperglycemia, wherein there is too much sugar in your blood. Wait a There is too much blood glucose, no? Now, listen, ha? Listen. Okay? Diabetes mellitus has 3 pathognomonic signs. When we say pathognomonic signs, common signs and symptoms, you will always see this, class. Okay? And I will explain them to you one by one. Polyuria, Polyuria is excessive urination. 3P's ni siya, class. Okay? 3P's of diabetes mellitus. Poly, deep siya. And polyphagia. Polydipsia, class, is excessive thirst. And polyphagia is excessive hunger. Okay? Now, what happens, mga good class, is this. Remember the concept of osmolality. Since there is a lot of glucose inside your blood vessel, it will make the blood highly concentrated. It will make the blood highly concentrated. Because of that concentration, class, it will increase the osmotic pressure and it will pull water. Listen to me, ha. It will pull water from outside the cell into the cell. Okay, it will pull water from outside the cell into the cell. So there will be a lot of water inside the blood vessel. Na daga na kay tubig, no? There is a lot of water. Now, because of that, class, listen to me. A lot of water will go to your where? Kidneys. Okay, because they are in the bloodstream, di ba? So they will go to the kidneys. Thus, you will have an increase in urination. Okay? Second, since there is not enough water entering the cell, the cell will undergo what we call cellular dehydration. Okay, cellular dehydration, wherein the cells will shrink. And this one, if the cells will shrink or if there is cellular dehydration, okay, it will trigger the thirst reflex. Thus giving you polydipsia. The third, since glucose is not entering, listen to me, ha, since glucose is not entering the cell will have what we call cellular hunger. Okay? And this cellular hunger will trigger your hunger reflex. Di ba? Hunger reflex. And thus, you will have polyphagia or excessive hunger. Okay. Another problem that comes with that is this. Since there is not enough insulin, okay? Since there is a decrease in insulin, okay? What happens is sugar cannot be metabolized. Glucose is not metabolized. And that's bad, class. We need glucose for energy, di ba? So what happens is fat catabolism. Occurs. When we say fat catabolism, class, it means that the fat is being broken down in order to create glucose. Fat is being broken down in order to create actually glycogen and then converted into glucose. Now, the problem there is this, no? Fat catabolism, class, often leaves a byproduct. And that byproduct, class, is our ketones. Okay? Now, ketones are very bad because ketones may cause metabolic acidosis. Okay? You will learn more about that in your MS. This is what we call, class, this is what we call the pathophysiology of what we call our diabetic ketoacidosis. Ayan. And that is exclusive for type 1 diabetes mellitus. Okay? Now, the thing about that is this. Since the problem here is that the pancreas cannot produce insulin, then we will give, listen to me, ha, this is very important. We can give insulin, but we cannot give OHA. We cannot give oral hyperglycemic agents. Nga naman, even if we keep stimulating the pancreas, it will have no effect because the pancreas itself is broken. So our treatment of choice here for type 1 is to give more insulin, to give or to replace insulin. So that is basically type 1 diabetes mellitus, no? Do you like my picture of the pork chop, class, no? It's raw pork chop and rice, but it suffices, no, for our discussion. Okay? Next, in contrast, is our diabetes mellitus type 2. Diabetes mellitus type 2 is also known as adult diabetes or non-insulin dependent diabetes mellitus. Okay, non-insulin dependent. The reason why it is called adult is usually this is acquired. Okay, ako is what in black class. Acquired DM. Acquired DM. Okay, also known often as obesity related DM. Okay, that is the major risk factor there, obesity. Now, what do you mean, class? What do we mean by this, no? What's the problem with this type of diabetes? Okay? Now, the problem is either there are two main mechanisms for this one. The problem is either the pancreas, okay, the pancreas produces very few insulin, gamay ra siya mahimo nga insulin. Okay, that's number one. Or number two, the insulin receptors do not accept insulin. This is what we call, class, insulin sensitivity. Okay, lagyan mo yan ng malaking star. Okay, that is the major problem. Now, here's what happens. Okay? Let's say, for example, you are a rabid eater. Kusog kay ka mukhaon, class. No? Kusog kay ka mukhaon. And because of your dietary habits, there is a lot of glucose. There is a lot of glucose there in your body. Okay? And that. Because of that, class, the pancreas will produce a lot of insulin. Himo po na siya daghan insulin. That is for the glucose, di ba? To help with the glucose. Okay. Now, as you know, the insulin will then go to your insulin receptors, and then they will open up the glucose transporter to allow glucose to enter the cell. Okay, glucose and potassium to be specific, no? Ato na i-appeal niya, class, potassium. Okay. Now, the problem is this. If sustained, your diet is sustained for a long time, like if your diet is very high in carbohydrates, very high in glucose, okay? Eventually, these insulin receptors will cease to function because they are being overused. Diba? Kung dagan kang ikaon, class, then there is more action, there is more need for insulin, and there is more need for activating the insulin receptors. So what happens is these insulin receptors will become overused. Magamit na sila, class. They are overused, and eventually they will no longer be sensitive. They will desensitize themselves to insulin. Dili na sila mo dawat. They will not accept insulin anymore. No, so they will not accept insulin. Now, because of that, class, since they do not accept insulin anymore, the glucose transporters are now closed, and we are stuck with the same problem. There is hyperglycemia. There will be polydipsia, polyuria, polyphagia. No? Now, the reason why it's called acquired is this will occur in a long time. This is a progressive disease that occurs throughout a long period of time. Okay? The reason why it's called adult is because this usually comes up when you are an adult. Diba? Because let's say, for example, during childhood, you are you love rice a lot. Nuksugay ka mukha of rice, no? During childhood, class, it will not affect you that much yet because your insulin receptors will still work. However, if you are exposed to carbohydrates for a long period of time, like for example, if your diet does not change, when you reach your mid-20s, your early 30s, then chances are at around 40 years old, your insulin receptors will no longer be able to work. And because of that, class, you will have what we call type 2 diabetes mellitus. Okay? Now, the good part about type 2 diabetes mellitus is that we can use insulin. Okay? We can use insulin, class, no? Because sometimes the problem is that the pancreas produces very few insulin. Gamay ra siya mahimo. And we can also use our oral hypoglycemic agents. Okay, we can also use our OHAs. So keep that in mind, ha? Keep this in mind. Oh, for type 2, we can use insulin in OHAs, but for type 1, we should only use our insulin. Okay, we will only use our insulin. So that is a basic pathophysiology of our diabetes mellitus. Okay? Now, what are our target blood glucose? This is represented, class, in milligrams per deciliter, no? mg per dl. Okay, mg per dl, ayan, no? And normally, when you are fasting, when we say fasting, class, it means to say you have not eaten yet, no? It should be around 80 to 100 milligrams per deciliter. If there is an increase, impaired glucose, let's say for example, you are eating a lot, no? It should be around 101 to 125. If it is greater than 126 fasting, then you might be diabetic. If you are gonna take the blood glucose measurement after eating, then normally it should be around 170 to 120 after eating, manggod, class, because remember, naman tayo gitawag nga postprandial hyperglycemia. So it is expected to be increased post-meal. If there is an impaired in glucose, it's 192 to 30. And then diabetic is 220 to 300. And if it is 2 hours, 2 to 3 hours after eating, then 120 to 140 for normal, 140 to 160 for impaired glucose, and diabetic is 200 plus, no? I just want you to keep in mind, class, the normal fasting, because usually that is what we use, normal fasting. Okay? Normal fasting. Now, we also have to discuss the HbA1 test. Now, the HbA1 test is a test that expresses the patient's compliance to insulin regimen, whether or not they take their insulin religiously within the past 3 months, because that is the key here. When it comes to insulin, dapat you must take it religiously. Normally, it should be less than 5.7%. Now, what is the mechanism for our HbA1c test? Class, this is our blood vessel. Our blood vessel, class, has hemoglobin. Okay, kanang red ha, that is hemoglobin. Now, typically speaking, no, sa ito'y color sa itong insulin, it's green, no? Typically speaking, insulin, not insulin, glucose, no? Glucose, if it is unused, okay, it will stick to your hemoglobin. Mupilit na siya sa imong hemoglobin, class. Okay? But hemoglobin, okay, hemoglobin has a lifespan of 90 to 120 days. So around 3 to 4 months. Meaning to say, after 4 months, after 3 to 4 months, no, all of the hemoglobin here will be destroyed by the pancreas, and then the body will create new hemoglobin that does not have your glucose. Wala na attached na glucose. Now, if, for example, class, you are taking your insulin religiously, okay? If you are taking your insulin religiously, if motomarkag insulin, class, then there will be very few insulin that is attached to your glucose. Insulin, there will be very few glucose that is attached to your hemoglobin. Very few. And the reason why is because most of the glucose will be moved to the cell na. To the cell. Because you are taking the insulin religiously. Diba? You are taking the insulin religiously. Okay? So, muna siya. Okay? That is our HbA1c test. No? Normally, it should be less than 5.7. If greater than 6 na siya, class, then that is a problem. It means to say the patient is not taking their insulin religiously. No? So, next is the preparation of insulin. Insulin vials often are concentrated. Okay, ang vials like this. No, like this. This is a vial. Insulin vials are often concentrated at 100 units per ml, or listen to me, 500 units per ml if short acting insulin. Okay? Because typically, class, this type of insulin, like for example, class, your Humulin R And Novolin R. Okay? They are typically used only for emergencies. Okay? Emergencies. Okay? Ay, wait. I have to confirm. Yeah. No, for emergencies. No, they are used for emergencies. Not only they are used for emergencies, but they are not exclusive to emergencies. No, so yung ano na siya 100 units per ml. And oftentimes this is expressed as like this, no, U100. When we say U100, it means that there are 100 units per ml. 100 units per ml. If you see U500, it means there are 500 units per ml. Okay? Now, here is the big thing. Lagyan mo yan ng malaking star. To prevent dosage errors, it is crucial. No. Not this is crucial. The nurse must ensure that there is a match between insulin concentration and the calibration on the syringe. Okay, lagyan mo yan ng malaking star class. This is to prevent you from killing your patients. Okay, this is to prevent you from killing your patients. Lagyan mo yan ng malaking star. Now, what do I mean? As you can see, this is the concentration, 100 units per ml. No? In your syringe class, you also have to ascertain that your syringe also shows 100 units per ml. Okay? 100 units per ml. Because class, the dosing for insulin is not like this. It's not like administer 1 ml of insulin. No. The dosage for insulin is oftentimes in units. So the doctor might say something like Novolin are 18 units. Kana? Novolin are 18 units. Now, I will teach you this right now. Please remember this class for the love of God. Okay? Each line is 2 units. Each line is 0.2 units. So, if I am going to give a drug that is 18 units, insulin that is 18 units, then I need to count, no? 2, 4, 6, 8. Ay, no, wait. 2, 4, 6, 8, 10. 12, 14, 16, 18. Meaning to say, I have to fill the syringe up to this point only. Because that is 18 units. Each calibration is worth 2 units. Each calibration line. Okay? Each calibration line is worth 2 units. Class, we are not gonna represent it in ml, ha? Keep this in mind, class. Lagyan mo yan ng malaking star, okay? This line. Each line is worth 2 units. Okay, so that is a by 2, no? By 2 na siya. If the medication order is 4 units, then you will only have to fill up to here. 'Di ba? Because this is 2, this is 4. So imura na siya puno until there. Okay, keep that in mind, class. Oh my God, 'di ba? No? So that is it. Now, here's the thing. Some insulins are cloudy. Cloudy in presentation. Okay? Now, you cannot immediately administer a cloudy insulin. So, what you need to do is you need to roll between your hands the vial. Okay? Roll between your hands the vial. Class, lagyan mo yan ng malaking star. Do not shake. Because shaking it, class, no? Shaking it will produce bubbles. And if you produce bubbles inside the vial, then it might alter, no, how you see the dosage. So it's much better to roll. Okay? Ayan. So that is the preparation of insulin. Don't worry, class, no? When you're gonna have your duty, you will be taught tudluan mo balik ani. Just make sure nga ang imong gigamit, the syringe that you are using is an insulin syringe. Okay? Typically, an insulin syringe is like this, no? There is no detachment of the needle. It is usually around 1 ml and the concentration is usually seen at the bottom. No? Kita agin ninyo ang concentration, class. Always look at the concentration first prior to administration. Okay? We also have pre-prepared syringes or pre-prepared insulin like this one, our Lantus Solustar, no? What you need to do, class, is this one here, the window here is already the number of units. Already the number of units. Now, the number of units, no, will depend on the what we call the patent, because some are by 10, some are by 1 unit. That's why it's very important, class, that before you administer a pre-prepared insulin, you need to check the manufacturer's instructions first, because some insulins like this one here, ilaha is by tens ang ilang unit, whereas this one here, it is by ones, no? Ones ang ilang unit, no? So you need to look at the manufacturer, and what you need to do, class, is very simple, class. If for example the order is Lantus 4 units, then you just need to twist the this part here, no, the mechanism, until number 4 is within that line. And once it is within that line, then you can immediately inject it. Pwede na natin mo siya i-inject. Okay? We also have insulin pumps, class, automatic insulin pumps and insulin patches. But I will leave that for your MS, because I know that there is a bigger discussion when it comes to insulin administration in your MS. Okay? Now, let's continue. The administration of insulin. Insulin is typically administered subcutaneously at a 45-degree angle to 90-degree angle. Okay? Only regular insulin can be administered by IV. The rest of the insulin should be administered subcutaneously, not intradermally, not intramuscularly, but subcutaneously. Because subcutaneous allows for absolute absorption of your insulin. Okay? And here is the thing. Usually, this is given in the morning. Nagsugod na ta, class. This is at the start of our nursing considerations. Okay? Usually given in the morning before breakfast, and can be given several times per day, usually before meals. Okay? The sites of injection should be rotated. Meaning to say, when we say rotated, you must need to constantly change it to prevent lipodystrophy, which is atrophy or hypertrophy. Atrophy, class, is when there is a indentation of fat tissue, because the fat tissue has atrophied or become smaller. Hypertrophy, class, you can see it if there is a bump of fat tissue. Ni burot, there is a bump of fat tissue. Now, what do I mean by rotate? Okay? Let's say, for example, class, I am giving the patient sa manirot na insulin. Let's use NPH insulin. Okay? Let's use NPH insulin. Okay? Let's say, for example, at 7 a.m. Wala lay dose. Okay? So, what I mean by that is I will choose a site. Okay? I will choose a site. Let's say, for example, I will inject here, and I will use that site for 1 week. I will use, when I say site, class, I am referring to this entire box, this entire area. Okay? Then I will choose an area. Let's say, I will use this entire site for 1 week. 1 week na, ha? Listen to me, 1 week. Now, I will use this area for day 1. On day 2, I will adjust 1.5 inches apart. Okay? So, for day 2, I will inject somewhere around here. Day 2. For day 3, nga rin na po, day 3. For day 4, day 4. Day 5, somewhere here. Day 6. And then day 7. No? Day 7. Okay? Now, since it is 1 week, I need to change my site. So, I will move to the other side for week number 2. Do you understand? Okay? Now, what if, sir, the insulin is given twice a day? Like, for example, at 7 a.m. and at 7 p.m. No. So in this instance, class, you will use two sites. Let's say, for example, this is for the 7 a.m. site and this is for the 7 p.m. And you can use these two sites for 1 week. So for example, day 1, 7 a.m. I will inject here. This is day 1. Day 1, 7 p.m. I will inject here. Day 2, here. And day 2, 7 p.m. here. Like that. No? It must be 1.5 inches apart. Okay? 1.5 inches apart. Now, the preferred location for injection, class, is in your abdomen. Okay? Skinning 3 and 4. This is the preferred. This is the best. Because of the thinness. Unsa kanipis, very thin. Fat layer, which allows for better digestion or absorption of the insulin. Okay? Now, that is for administration. It's very crucial that you understand this, class. Okay? Now, here is a list of the types of insulin. There are a lot of types, class. We have rapid acting, short acting, intermediate acting, long acting, and combination insulins. Okay? Listen to me. I want you to listen, class. For the love of God. Okay? For the love of God, I want you to memorize this table. Memorize this table, class. Okay? Because timing is crucial. What I mean that literally. Okay? Timing is crucial, class, in the sense that we need to consider that these drugs often have an onset, a peak, and a duration. Now, why does it matter? Why is timing crucial? Okay? Now, the reason why is this. When more insulin is administered than required for glucose metabolism, then a hypoglycemic reaction, or otherwise known as insulin shock, may occur. Okay? And this most commonly occurs during the peak. Now, why is this important? Remember, oftentimes, guys, these insulins can be mixed. Okay? Okay? Now, I will give you a scenario and I will show you what I mean. Okay? Using this chart. In the y-axis, I have the level of blood glucose. In the x-axis, I have the number of hours. Okay? Now, a patient who has hypoglycemia or has diabetes mellitus oftentimes will have a very high blood glucose. Okay? Represented here in red. Taas na siya blood glucose, class. Okay? They often have a high blood glucose. Now, listen to me. Okay? Our target is between 100 to 80. Diba? Because that is normal for fasting. No? Now, let's say for example, class, listen to me ha. Let's say for example, ang doktor kay bulok, ang doktor kay tanga. Okay? Now, what I mean by that is, let's say for example, class, they ordered 2 insulins. They ordered, let's say for example, Lispro, and let's say for example, they also ordered Aspart. Okay? Lispro and Aspart. Okay, ayan, no? Now, what's the problem with that, sir? Okay, tanaw ha. Lispro, class, okay, which I will represent in blue. Do not mind this yet. Ayaw sa tanawa. Okay, do not mind this yet. Lispro, I will represent in blue, okay, has an onset of 15 minutes. Okay? It has an onset of 15 minutes, yumalog, no? It has an onset of 15 minutes. It has a peak of 30 to 90 minutes. Okay? So let's say for example 1 hour, no? Now, sige. It has an onset of 15 ha. So at the start, it's very low ang yung level. And then it will start at around 15. Okay? 15. Listen. And then it will peak. Musaka nagpumayo class, no? It will peak, no? When it reaches 1 hour to 90 minutes, and then it will stay at its peak until its duration ends, which is around 2 to 5 hours. So let's say 3 hours, no? So peak na siya for 3 hours, and then it will go down. It will slowly go down, no? It will slowly go down until 5 hours, wherein munaog na gina siya class. Okay, that is for our Lispro. Okay. Now, since there is insulin, and the insulin peaks at around 1 hour to 3 hours, then it means to say at this point, the blood sugar will also go down. Okay, the blood sugar will also go down, go back to normal, no? Because it's tandem man, di ba? It's tandem, no? Sakang yung insulin, then the blood sugar will decrease. Now, since the doctor also gave aspart, which we will represent in green, okay? Since the doctor gave us aspart, remember, aspart also onsets at around 5 to 15 minutes. Okay? Aspart also onsets 5 to 15 minutes, and its peak is around 1 to 3 hours as well. Okay? So, onsets at same time, and then it peaks at around, let's say for example, 1 to 3 hours. Nga ridapit. Let's say for that, like that. And it has a duration of 3 to 5 hours, no? 3 to 5 hours. Let's say at around 3 to 5, munaog na siya diri class. It will now decrease, no? That is our aspart. Okay? Now the problem there is this, no? At this time here, tanaw ha, the one I am putting black bars here. At this time here, there are 2 insulins that are peaking. And because of that insulin peak class, because there is 2 insulins at the same time class, your blood sugar, kaya to sa drawing yung tarong ha, your blood sugar, since there are 2 insulins, will go down very hard during those times. Di ba? Manaog na siya pamayo class like this, oh. It will go down during those times, no? And then it will slowly increase back up, no? Now that is a big problem. Okay? Because if the insulin goes below the target, then that is what we call hypoglycemia na. Low blood sugar. And remember, hypoglycemia is more dangerous than hyperglycemia. Because hypoglycemia can lead to coma and even death. So, muna siyang atong gitawag class nga, that's what we call hypoglycemic reaction because 2 insulins are peaking at the same time. Okay? So, what's ideal, sir? Ano may ideal, sir? Okay. Ano may ideal, sir? Ha? Look at this. This is the ideal one. Remember, a patient with high blood glucose or diabetes will have very high insulin for most of the day. So what we need to do is instead, what they often prescribe is instead, they will give NPH. NPH class is intermediate. And then they will give regular insulin, which is short acting. Now, regular insulin class has an onset of about 10 minutes to 1 hour. So let's say for example, it onsets at around 30 minutes. Okay, nga rin siya start. Now, it starts here. And then it goes up. Okay, it goes up. And then it peaks at around 2 hours. No? 2 hours, 2 hours, 3 hours. Yan. It peaks at around 2 to 5 hours. So let's say it peaks. Let's say it peaks at around 3 hours. No? So sige na siya saka. And then it peaks at 3 hours. And it sustains its peak up until like 5 hours. Okay? So manaog siya dire. At around 5 hours. Yan. That is our regular. Now, During the peak class, remember, Siyang, ayaw Siyang. Nagklase ko Siyang, no, later na. Okay? So, your insulin or your blood sugar will also decrease during those peaks. Diba? Munaog po na siya, class. No? It will slowly go down. And it will do something like that. Okay? Now, munaog siya, it goes back to normal. No? Now, the reason why we give regular and NPH in this instance is so that we can maintain a stable blood sugar for a long time. What I mean by that is this. Look, if I draw out the curve for NPH, which I will represent in blue, okay, it starts at around 1 to 2 hours. So let's say it starts at around here, okay, and then it will slowly go up and it will peak at around 6 hours. No, so it will go up. Sige na siya saka, class. Sige na siya saka. No, sige na siya saka. Okay? And then it will peak at around, ayaw, ba't pagka-drawing? No, and it will peak at around 6 hours, di ba? 6 hours to 12, no? And then it will keep on peaking up until 12 hours. So because the insulins, no, they are not peaking together, means to say that the blood sugar, no, can effectively be straightened out. Okay? And nara siya slight increase during the time when none of it is peaking. No? There will be a slight increase when none of it is peaking. But the rest, if you see, the NPH, no, as you can see, no, it allows us to make sure that the blood sugar is consistently within our target range. Okay? Within our target range. So that is the reason why we often mix insulins, so that we can keep the blood glucose levels consistent throughout a longer period of time. That's why, class, oftentimes they do not mix rapid and rapid, because if you mix lispro and aspart, they will peak together at around the same time. And that will cause a hypoglycemic reaction. That's why timing is crucial when it comes to these drugs. That's why it's very important that you memorize this table. I am urging you right now, class, if you want to become a nurse, if you want to pass the board exam, if you want to pass the NCLEX, memorize this table. There's no other way. Memorize this table. Okay? So, let's continue. Okay? Since oftentimes NPH and regular nilang gamiton, class, remember that you can mix these drugs. Mix into one syringe. Okay? Now, the problem there is a specific way that we need to mix it. Okay? Now, typically speaking, no, how to mix our insulin. When we mix NPH and regular, no, remember, class, that NPH is often cloudy. So before you mix your NPH and regular, you must roll first. Roll NPH first. Okay? Roll NPH first. After that, class, okay, listen to me, ha. After that, you will inject air in cloudy. So inject air. You will aspirate air into the NPH. After that, you will aspirate air in the clear, which is your regular, no? Aspirate air into the clear. After that, balihon mo, class, okay? You will reverse the vial, okay? Reverse the vial, and then you will draw up, okay? You will draw up regular first, the clear first, okay? You will draw up, kuhaonin mo ang insulin sa clear first, and then you will draw up the cloudy or the NPH last. Okay? In order for you to memorize this, class, remember, class, when it comes to aspirating air, remember N to R. Meaning to say NPH to regular. And then when it comes to mixing, then R to N. Okay, R to N. Regular first and then NPH. Okay, that is how you mix insulins. Dili pwede basta-basta lang, class, no? You should not do it willy-nilly. Para dili ka makalimot, class, no? I just remember you are not, okay, not retired, NR, di ba? You are an RN. Ayan, you are not retired, you are an RN, di ba? So, para di ko makalimot, class, N to R, when aspirating air, NPH first, and then regular, cloudy or cloudy first, then clear, and then when you are mixing, then clear first, regular, and then cloudy after, NPH, no? So, that is how we mix our insulins, okay? Now, let's have an NCLEX practice question. Mrs. Potts is to be administered with Humalog 18 units subcutaneously before every meal for 2 days. How fast is the onset? This is the reason why I'm telling you. These are the common questions class in the board exam. Tana na sila kung sa kapaspas ang onset, no? And typically, the tables that we use are standardized, so you will know. That's why you need to memorize class, no? So if you look, Humalog, if you look up Humalog or Lispro, its onset is 5 to 15 units. So ang answer ani class is 5 to 15 units naman, no? 5 to 15 minutes. Okay? Lagyan mo yung malaking star. That's good if there are multiple choices. Because if nagaling multiple choice, then you might be able to see the answer if you memorize it easily. However, class, if you're gonna take the NCLEX class, expect lang that there are some questions that are not multiple choice, no? Like this next question, class. Okay? The physician orders 10 units of Humulin R and 12 units of Humulin N. Humulin R gani class, that is regular insulin. And Humulin N, that is NPH insulin. Before breakfast. Remember ha, ang kani ato regular, this is short acting, while our NPH is intermediate acting. So same sa atong akong gipakita ganina, it's very similar, no? You are required to mix these medications into one syringe for administration. Correctly put in order the steps of how you will perform this procedure. Okay? So first thing that you need to do is obviously wash your hands. So this is first. Wash your hands. Second class is wear your gloves. Diba? Don your gloves. No? Don your gloves. Thirdly, class, is this. Thirdly, if you're not unsure, if you're unsure, no? You don't know if 2 ba or 6. Class, okay, listen to me ha. The answer is number 6. This is the third. As I mentioned before, you should roll the Humulin N first. Okay? Before you try to aspirate. Diba? And the action of aspirating good class requires you to clean each vial top off with alcohol. So before you even before you even clean it class, roll it ahead of time. So that after rolling, you can clean it off na. Okay? So number 4, the fourth is clean each vial top with alcohol. Okay, and now we can start with aspirating air. Remember, when it comes to aspirating air, we start with a cloudy first. Cloudy, also known as our what? Humulin N. So, the fifth step is number 7. Inject 12 units of air. Okay? After that, what do? We inject 10 units of air into Humulin R. Diba? NR, NPH first, and then next is regular insulin. No? So 6. This is number 6 in our steps. No? So now we are gonna withdraw 10 units. We are gonna put it in the syringe. Now we are gonna withdraw. When it comes to withdrawal or mixing, we start with R. So that is number 7. This is our 7th step. And our 8th step is lastly, we withdraw Humulin N or NPH, no? This is our 8th step. So, the answer for this one is 8, 3, 6, 2, 7, 4, 1, 5. Okay? There are questions kasi in the NCLEX like that, step by step. So, dapat ka mauka. Okay? Next is the storage of insulin. Unopened vials are refrigerated until needed. Not freezer class, only the body of the fridge. We don't want the insulin to freeze. If you freeze the insulin class, then it's no longer allowed to be used. So it's already damaged because it will crystallize, no? If opened, it may be kept at room temperature for 1 month or in the refrigerator for 3 months. After 3 months, class, after 3 months, okay, insulin becomes weaker. No? Insulin becomes weaker. If it is pre-filled insulin, store in the refrigerator only up to 2 weeks. Okay? If unused in 2 weeks, then throw away. Because kini sila class, kini mga pre-filled class, no, they have a very, very sensitive. They are very sensitive to temperatures, no? So, that's how we store insulin. Lagyan mo yan ng malaking star class. These are also big questions, no, in the exam. Okay? We can also give insulin by a sliding scale. Insulin may be administered in adjusted doses that depend on the individual's blood glucose test results. Okay? Testing, class, listen to me ha. Testing must occur before meals or at bedtime. Okay? Now, let's say, for example, class, a patient at 7 a.m. has a blood glucose level of 214 milligrams per deciliter. If the doctor, listen to me, if the doctor prescribes a sliding scale like this, it is a table, an interpretation table, then you will use this to determine your dose. For example, class, since ang iyahang 7 a.m. is 214 milligrams, we can deduce that we need to give him, which is in between 200 to 249, 2 units of insulin. So, give 2 units. Okay? But however, let's say for example, at 7 p.m. before bedtime, let's say for example, ang iyang blood glucose class is 342 milligrams per deciliter. Okay? So, what do? We need to adjust, di ba? 342 is in between 300 to 349, which means to say we will give the patient 6 units. Give 6 units of insulin. Actually, class, insulin sliding scale coverage. Sliding scale coverage for insulin is the most common way in which we give insulin in the hospital. I'm telling you, no? I'm telling you, you need to be familiar with this. Oftentimes, the doctor will give you a sliding scale to follow, no, your dosing. So nga na siya. Okay, so what do we need to consider? Identify the drugs that the patient currently takes as aspirin, anticoagulants, oral antidiabetics, beta blockers, tricyclic antidepressants, and monoamine oxidase inhibitors may increase the hypoglycemic effect when taken with insulin. Okay? While thiazides, glucocorticoids, oral contraceptives, thyroid drugs can increase blood sugar. So, as a nurse, it is very important that you identify what other drugs the patient is taking, because these drugs might affect our insulin therapy. Okay? Monitor the patient's blood pressure, heart rate, and blood glucose levels, as tachycardia and heart palpitations present with hypoglycemia, while hypotension may occur in hyperglycemia. Okay? Hyperglycemia. So keep that in mind when you're taking these drugs, no? Teach the patient to recognize and report signs and symptoms of a hypoglycemic reaction. Remember, hypoglycemic reactions often occur when 2 peaks of insulin or insulin peaks at a very unfortunate time, no? So, hypoglycemic reaction signs and symptoms have include headaches, sweating, tremors, and a rapid pulse. Diba? Especially sweating, class, no? Another is disorientation. You could also say dizziness. We can also teach the patient to recognize and report signs of hyperglycemic reactions. Hyperglycemic reactions, class, is similar to what I mentioned before, the class, the diabetic ketoacidosis, in which there is too much glucose in the blood, and it is not being used by the cells, so fat catabolism occurs. What happens, class? What happens there is you will oftentimes have increased urine output, thirst, and a sweet, fruity breath odor. This is due to presence of ketones. And this is a sign of diabetic ketoacidosis. But increased urine output and thirst, this is polyuria. And this is polydipsia. Okay? These are the common signs of hyperglycemia. You need to report that as well. Okay? Explain that orange juice, sugar-containing drinks, and hard candy may be used when a hypoglycemic reaction begins. The problem with hypoglycemia is there is not enough blood glucose. Diba? So, orange juice, sugar-containing drinks, and hard candies, these are fast sugars. Fast sugars to alleviate a decrease in blood glucose. Okay? Instruct the patient on how to check blood glucose with a glucometer. Okay, I know some of you have been taught this before in your health assessment, but and also your subject, health education. But don't worry, you will be taught this in your MS, okay? And in your duty as well, no? Teach patient about care of insulin container and syringes. Inform patient taking insulin, NPH insulin with regular insulin that regular insulin is drawn up before NPH insulin. As I've taught you before, you should also teach that to your patient, okay? Class, the thing about that is this, okay? For insulins class, there are a lot more nursing considerations. No. I am just teaching you the most basic nursing considerations. And the reason why is because it's very hard to discuss the other nursing considerations if you do not have a background in medical surgical nursing. I know this will be discussed to you again. Okay? This will be discussed to you again in your MS. This is just a precursor. No, I'm just teaching you the effects of the drugs. Keep that in mind. Okay? Don't worry, class. This will be discussed further when you reach your MS. But mo gini siya, I'm teaching you the very basics usually about drugs. Because the other nursing considerations, mga good class, the other nursing considerations for insulin revolve around complications of insulin therapy. Like for example, if moingon ko, if you give insulin, it might cause hypoglycemia, and hypoglycemia might cause, it's very difficult to understand if you don't have a background with MS. So that's the reason why. And let us now proceed with our... Okay, so our oral hypoglycemics. Remember class, actually there are a lot of classifications, not only our sulfonylureas, big one nights, and alpha glucosidase inhibitors, but napatay lain. No, but I ask you to further read on them because they are not that commonly used. Oftentimes these three are the most commonly used, and some of them, like for example our GLP-1 inhibitors, agonists, they are so new to the point nga I was there when they were being introduced. I was already a nursing student, no? So let's focus on these three lang, so that we can save on time, because I know some of you might have problems. Kaya nagklase pa ko. Might have problems with access, no? So remember, our oral hypoglycemic agents, they are not used for type 1 diabetes mellitus, but they can be used for type 2. Okay, never use them for type 1 class. Okay, they can be used for type 2. Oftentimes, no, listen to me, oftentimes in conjunction with insulin. Okay, in conjunction with insulin. Now, the side effects for most of these drugs are similar to side effects of insulin. Okay? Similar to the side effects of insulin. Now, sa may mga side effects of insulin, sir? The side effect of insulin is kini mga hypoglycemic reactions, no? Hypoglycemic reactions, our hyperglycemic reactions, if it's not enough, no? So that's the gist of it. Now here's our criteria. This is the guidelines for OHA therapy, or the criteria. The onset of the diabetes mellitus must be at age 40 or older, mean to say it is type 2 diabetes mellitus or adult diabetes mellitus or non-insulin dependent. The diagnosis of diabetes must be less than 5 years, less than as a class. The patient's weight must be either normal or overweight, The fasting blood glucose must be less than 200 milligrams per deciliter. If greater than 200 milligrams per deciliter, manggod kas, oftentimes, they will give insulin na. Okay? Less than 40 units of insulin required per day. And then the patient must have normal kidney and liver function. So let's start with our first classification, our sulfonylureas. Now there are 2 generations, and each generation will have a different action compared to the other. Okay? So our first generation class, they will stimulate the beta cells to secrete more insulin. Okay? And also increases the ability to bind with the insulin receptor. So very good. They will address the 2 problems with type 2 diabetes, wherein the problem is there is not enough insulin being produced and the insulin receptors are not sensitive, or they do not want to use the insulin. No? So it's very good. Type 1. Type 2 class increases the tissue response to insulin and decreases glucose production. When you decrease glucose production, class, you are directly decreasing blood glucose. Okay? While increasing the tissue response to insulin is similar to increasing binding ability to insulin receptors. Yan. That's our second generation action. Our first generation sulfonylureas nursing considerations, no? It will include the following drugs: tolbutamide, tolazamide, and chlorpropramide diabetes. No? These are short, intermediate, and long. This is first generation, by the way. No? This is contraindicated in patients with a sulfa allergy. Sulfa gani class, meaning to say sulfur-based products. No? Sulfur-based products. Now, if it is sulfur-based, no? Remember, sulfur-based oftentimes causes high photosensitivity. No? So you already know what to do with photosensitivity, di ba? This is also contraindicated in patients with type 1 DM, because in type 1 DM, remember, the problem is the pancreas cannot produce insulin. So even if you keep stimulating the beta cells, it will not produce the insulin, di ba? Warn the patients to avoid alcohol, as this can cause this can potentiate, no, the hypoglycemic effect of this drug, which will possibly cause hypoglycemia. Administer 30 minutes before meals, and regular monitoring of blood glucose to ensure the effectiveness of this drug is required. No, typically monitoring should occur 30 minutes after giving the drugs. No, 30 minutes before and 30 minutes after giving the drug. Second generation sulfonylureas, okay, such as our glipizide or glucotrol, our glyburide, diabeta, and our glimepiride. They have similar nursing considerations to our first generation. In that, no, the thing you need to remember about this one is that they have a greater potency than first generation. Okay, they have greater potency. So higher risk po na siya, class. Higher risk for hypoglycemic reactions, di ba? It also has a longer duration of action and fewer side effects, and this can be used in combination with insulin. First generation class can also be used with insulin, but mas preferred lang gid nato ang second generation. Okay, we just prefer second generation more. That's why this is more commonly used now kini mga gly and mga gli, no? This is contraindicated in patients with liver or kidney dysfunction, pregnant patients, and type 1 DM, no? Because there is a higher chance for hyperglycemic reaction, because as I mentioned before, it's more potent, no? You need to monitor patients who are elderly, Because elderly patients often have weaker liver and kidney functioning, and this drug, no, it can affect liver and kidney functioning, especially the kidney, because it's part of the excretion, manggod, no. Administer 30 minutes before meals, monitor the patient's blood glucose, and instruct the patient to avoid alcohol, similar to our first generation, no, similar to our first generation. So that's our sulfonylureas. Okay. Nainawtanan ako, sir, why do you need to avoid alcohol? The reason why you need to avoid alcohol is that alcohol, okay, when given with these drugs, can cause a disulfiram like reaction. A disulfiram like reaction, it of commonly has nausea and vomiting. It has diarrhea, no, because this is the body trying to expel, trying to release, no. Iya gipagawas ang atong what we call alcohol. Iya gipagawas ang atong alcohol, no. So next is our biguanides. Biguanides decrease hepatic production of glucose from stored glycogen. So this decreases glycogenolysis. This decreases serum glucose postprandial by decreasing the absorption of glucose from the small intestine. So kumbaga, overall, this will decrease the level of blood glucose, no? Decrease blood glucose mainly by decreasing absorption of glucose. Okay? Post-meal. Pinaka-common example ani class, and pinaka-common gyud na drug that they use for type 2 diabetes is metformin or glucophage ang yung brand name. Metformin. No, muna pinaka-common class, no? This does not produce hypoglycemia or hyperglycemia effects. However, this does cause GI disturbances. Lagyan mo yan ng malaking star. Okay, muna siyang yung pinaka, that is its most prominent side effect. And because of that, this must be taken with food or during meals. Not unlike your sulfonylureas, which you should take before meals. This one you should take during meals. Okay. The monitoring of blood glucose is crucial. Obviously, this is contraindicated in patients with renal impairment, because if there is renal impairment, there is impairment of excretion of metformin. Dili ma-excrete ang metformin. Okay? And this is a key one, class. Lagyan mo yan ng malaking star, no? Metformin should be stopped at 48 hours. 48 hours prior to any imaging. When I say imaging, class, that could include something like X-ray, that could CT scan, that uses contrast. Okay? When I say contrast, class, it means that they will inject a dye. No? Inject a dye to visualize organs. Okay? The reason why is because metformin oftentimes interacts with the dye that may cause lactic acidosis and acute renal failure. Okay? Lactic acidosis and acute renal failure. So, you should stop the metformin 48 hours before any imaging so that the metformin is excreted. That's why it is contraindicated in patients with renal impairment. Diba? Lastly, class, is our alpha-glucosidase inhibitors, no? Alpha-glucosidase inhibitors, this is very nice because it has a direct effect on the GI tract itself. Okay? What I mean by that is that it will inhibit the digestive enzyme. The digestive enzyme in this case is our alpha-glucosidase. Of course, no? In the small intestine that is responsible for the release of glucose from complex carbohydrate. Kasi alpha-glucosidase, mga class, no? Alpha-glucosidase, the reason why alpha-glucosidase, it is responsible for breaking down complex sugars, like your starches into glucose. Okay? So if you stop alpha glucosidase, then you will not be able to create glucose, no? So in turn, this will decrease glucose, di ba? Very simple, no? Simple lang yung mga mechanism. We have two drugs, our acarbose precoce and our miglitol glycet. Okay? What do we need to do? What do we need to remember about these drugs, no? This must be taken with meals because they have a direct effect on the GI, which means to say they have a tendency to cause gastric upset, okay? If it causes hypoglycemia, which is a very rare occurrence by the way, simple sugars such as candies will not work. Because absorption, remember, absorption is being blocked. Di ba? That is what it's doing. It is blocking the release of glucose from complex carbohydrates. No? So, what you need to do instead is instead of giving them simple sugars such as candies or orange juice, no? Instruct the patient to carry oral glucose tablets. So that when they take the oral glucose tablets, the body will not need to digest it anymore. They will not need to break down the sugar into glucose anymore. It's already glucose, di ba? Monitor the patient's blood glucose. This is constant for all of our medications here. And this is contraindicated in patients with inflammatory bowel disease and patients with digestion problems because as I mentioned before, this has a direct effect on blocking specific types of digestion. No? So that's why we don't give it to patients with digestion problems. Okay? And inflammatory bowel disease. So these drugs class, actually they're very simple mga good class. The hard part about antidiabetics is insulin good class, no? Insulin. For our further readings, I want you to read about thiazolidinodions, meglitinides, and our GLP-1 agonist. The reason why I am asking you to further read it is your sources might be better than mine. Right now, mga good class, these are either too uncommon, okay, or too new. Lang example na class no, GLP-1 agonist. An example of a GLP-1 agonist is semaglutide, also known commercially as your Ozempic. Now, this drug class, I remember it's so new. Bag-o jud na siya class to the point nga I was there when it was just being discussed here in the Philippines for the first time. There was an American nurse, doctor of nursing from North Carolina. He went to the Philippine Nurses Association, and the reason why invite ang University of the Visayas at that time was because he had a colleague who said nga i-invite ang University of the Visayas, so gi-invite nyo sa kaseksyonan. And he was there, no, basically to teach us the new methods or new drugs when it comes to diabetes. And at that time, bago pa ni siya class, GLP-1 inhibitor, and that was around 2019 or 2018, I forget, no? But it's really recent, no? I want you to study on this one. I will still include this in the exam. The reason why is sa ako among sources, it's uncommon man good, no? And there's not enough information. Technically speaking, there's not a lot of information about these drugs yet, no? So mo na siya, further read lang. I will include some but not all. I will focus mostly on insulin.